just a couple of minutes ahead of time. And today's, thank you all for coming. And today's IC deals with retinal imaging in a different slight of way. We're trying to go into some of the main, the facets, the main pillars of retinal imaging, which are not usually dealt in with great detail. So I have a very excellent expert panel who is along with me, Dr. Manoj, the Chief Vitreoretinal Surgeon at Chaitanya Eye Hospital, Dr. Anand Rajendran, the Head of Vitreoretina at Arvind Eye Care, Dr. Daraya Shroff, the Head of the VR Consultant from Shroff Eye Care, Dr. Shade Matthew, who is the Chief VR Surgeon from Chaitanya in Tiruvalla, and Dr. Ashish Sharma from the Lotus Group of Eye Hospitals in Coimbatore. So what we're going to do is start from a new modality in imaging, which is the multicolor imaging of the fundus. And Dr. Manoj, with his lucid talk, will tell us that it is just not about color photography. Dr. Manoj, I'm handing it over to you.
Thank you, Dr. Oni. So my talk will be on multicolor imaging of the fundus. Multicolor scanning laser imaging is a recently introduced innovative technology developed for spectralis OCT, and it is fast on its way to replace the traditional flash-based fundus photography. Now it's part of the multimodal imaging platform, which is a current trend in retinal imaging. Now what this basically is, it involves three lasers. There is a blue laser, green laser, and infrared laser. And the infrared laser visualizes structures at the level of the outer retina and the choroid, captures images from this level. The green laser obtains images from the retinal blood vessels, hemorrhages, and exudates as the middle retina. And the blue laser obtains information from the surface, the vitreoretinal interface, and the inner retina. And all these information from these three laser images can be integrated to form a composite multicolor image. So this is the basic principle of multicolor image. Now why is multicolor image better? Now this platform utilizes the confocal technology and thus has unique advantages over the conventional flash-based fundus photography. It provides good image quality in hazy media and in small pupil. It does not use bright white light and thus is not discomforting to the patient. The images obtained are better contrast and sharper borders and compared to the flash-based photography. And further, patients requiring OCT can be imaged in the same machine and need not go to a different machine to obtain photographs. So it is not a fancy tool. The superiority of multicolor imaging is reported in various retinal conditions. Now I'll be showing you some case examples trying to prove this point. Now multicolor imaging is believed to be better than normal color fundus photography in demonstrating some pathological process. Now look at these examples. These are patients with epiretinal membranes. So you can see on the right side is an image with the multicolor. You can see the greenish tinge of the epiretinal membrane. The extent of the epiretinal membrane is well seen. You can also see the surrounding ILM folds. So as you can see here, it's very obvious that these surface disorders, multicolor imaging is superior to the fundus photography. Now this is an example of a patient with early diabetic retinopathy. So all these small microaneurysms can be seen very clearly. The small dot hemorrhages, microaneurysms can be seen. You could use a green channel laser images, which acts just like the bread-free image. You can see these dots as black dots. And studies have shown that this is again superior to flash photography in picking up early forms of diabetic retinopathy. Again, in diabetic macular edema, you can see this greenish tinge over here. This demonstrates the diffuse macular edema in this patient. And here you have a focal macular edema. The greenish tinge denotes the thickness of the retina, and you can also see an adjacent epiretinal membrane. So multicolor is very useful to pick up diabetic macular edema as well. Now this is an example of a PDR. You have this fibrotic so in addition to what you see clinically, you can also see this thickened posterior hyaloid, which is very well seen on the multicolor image. Now consider this example here. Here, if you look at the fundus, it looks apparently normal. But if you look at the multicolor image, you can see this increased red reflectivity here, parafoveal region. And again, if you see carefully, you can see a zone of increased red reflectance there. This is a patient with right eye parafoveal PED, and the other eye has a CSR. So things which are not seen obviously on a clinical examination are well seen on the multicolor image. This another example here, apparently looking normal except for a few pigmentation here This is a patient with MACTEL, non-proliferative. You can see the increased red reflectance in the perifoveal region, which corresponds to the OCT ellipsoid zone there and the abnormality that you see in the retina in both eyes. Now another example here, patient with drusense. What you see is drusense. But what you see now in the multicolor is, in addition to the typical drusense, you also see this green reflectance here, green dots over here. These represent the retinal pseudodrusense, which are often missed on a clinical examination. And studies have shown that multicolor is definitely better to detect soft drusense, reticular drusense, retinal atrophy, and fibrosis, and is better than fundus flash photography. Another example here, Nevis. See that this is the clinical photograph and this is the Nevis. You can see the margins of the Nevis are very well defined here. Nevis, you know, we need to know the margins in terms of follow-up. It is much better than all the other investigative modalities. This is the autofluorescence and this is the angiogram. So fundus multicolor image definitely is better than all the other modalities in studying patients with Nevis. Multicolor also helps in understanding and identifying certain critical features in some diseases. Like you see, this is a patient. We know that in geographic atrophy, the best investigation is fundus autofluorescence, and basically to study macular sparing, this is very useful. Multicolor imaging closely mimics what you see on the fundus autofluorescence. Sometimes now it even gives us better information. Like this patient has a CNVM already in one eye lost, other eye had some 6/9 vision. If you look at the autofluorescence, you see that it's all decreased autofluorescence. But if you look at the multicolor, you can see this red reflectance, which shows that the central fovea is not involved, and therefore this patient has a relatively good vision. So studies have shown that multicolor and fundus autofluorescence shows the greatest agreement for geographic atrophy measurement and is very useful during follow-up. Consider this example here. This is a patient. You see on the multicolor image, you see an increased reflectance over here in the central region. And this is the IR image. And if you look at the OCT through this, to that image, what you see is you see some ellipsoid zone layer. There's no fluid there, but what you see is pachyvessels. So in this example here, multicolor could identify this patient having pachychoroid vasculopathy. This is emboli there, retinal arterial emboli, which is very well seen on multicolor image. You see the greenish tinge to these emboli, and sometimes small emboli which can be missed can easily be picked up on a multicolor image. It also helps us to differentiate some pathological conditions. Like in this, it's very useful to differentiate between true disc edema and pseudo disc edemas, and this has been published in literature. In true disc edemas, you don't see a greenish tinge, whereas in pseudo disc edemas, you don't see a greenish tinge, but in true disc edemas, you see a greenish tinge. Sometimes you see this greenish ring around it, and that is described along with the obscuration of blood vessels, and this has been published again in literature. It's also useful to differentiate between acute and chronic CSR. This is acute CSR. You see this dome-shaped greenish reflectivity here, whereas here you see a diffuse reflectivity. This is chronic CSR. This is acute CSR. You also have the infrared image, which closely mimics the autofluorescence. Again, in osteomers, in calcified osteomers, you have this greenish tinge. In decalcified osteomers, you have this reddish tinge. This patient also has a CNVM. So it helps us to differentiate between these two entities. Sometimes it gives as much information as angiography. Look at this patient here. This is a CSR. You see this greenish tinge of the fluid. You also see the subtle folds. But what you also see this increased red reflectivity here that comes from the infrared laser. And if you look at the ICG, you see this increased hyperpermeable choroidal vessels, and closely reflects that. Now it gives as much information as you would see on the ICG. Another example here, you see this increased reflectivity here, which corresponds to the area of macular telangiectasia. This is a patient, you can see here the perifoveal abnormal telangiectic vessels. But what it also shows is an area of increased reflectivity over here, which corresponds to the subretinal neovascularization, which is seen on the avascular slab. So it is very useful to pick up these abnormalities and closely mirrors what we see on an angiogram. It also helps us to identify certain rare presentations which could easily be missed. Like I said before, the retinal pseudodrusense, we know that these are now called as subretinal drusenoid deposits because they lie between the retinal pigment epithelium and the photoreceptors. This example here, this patient had a CNVM in one eye, and a casual photograph in the other eye revealed this thing. You see this increased red reflectivity over here. When the OCT did show a shallow PED with a double layer sign. But when we did an OCT angiogram, what it also showed is the presence of a CNVM in the choriocapillary layer. So this is a patient of non-exudative CNVM, which is not exuding fluid, which could be picked up, suspected on the basis of multicolor image. Nerve fiber layer again is better seen in with the multicolor image, and you can also look at the blue and the green images closely mirrors the red-free image. In patients with asteroid hyalosis here, there's a fundus photograph which you cannot see anything. But if you do the multicolor, because it's laser, you can pick up what is the underlying retina. You can see the hemorrhages over here. This patient also had a CME, and there's another patient here, PDR, which could not be seen on a clinical fundus photography. Again, a patient with cataract going for surgery. Multicolor showed this increased green reflectance, which corresponded to the fluid that was seen on the OCT. So it is also useful as a pre-operative tool. Like this is a patient with globally adherent ERM, which is going for surgery. Now, if you look at the multicolor image, you know that you see this pocket here. This is the area where it's kind of lifted off, and that is where you could start peeling. So it gives us an idea as to where to start peeling. Sorry, I'm just finishing. There's another patient here with thickened posterior hyaloid here. It also tells you the extent of peeling that is necessary, and this is something which we found recently, that you could see the extent of ILM peeling. This is a post-ILM peeling patient, macular hole case, where you can see the extent of ILM peeling. When you have to repeel, you could use this as a guide to decide where to peel. And also you see the red reflectance here. This corresponds to the dissociated optic nerve fiber layer defect that is reported in patients where you have aggressive peeling. So you could also tweak the colors and get more information. Now this is a standard color image that you get, but if you could also go into this enhanced green-red reflectance and also use a user-defined reflectance, you can go and play with the color images and obtain more information. You can get a blue image, you can get a green image, and all these may add up, may give you some information. Like here, the automated green-blue enhanced image showing the nerve fiber layer very well. So we should also be aware of certain artifacts, and we should also be aware of the fact that the color that you see in multicolor may not be exactly the color that we clinically see in the patient. So these are artifacts, the ghost artifacts, bevel artifacts. So you see this is a pigmented lesion which may appear red on multicolor. So that you should keep in mind. So this is a drusen which is appearing red. This is important. You see, this is a mactel where you see pigmentation which may appear red. You should not be thinking it's a hemorrhage and think of a neovascular process. So to conclude, multicolor imaging is a dynamic fundus photography. It helps us to gain better understanding of the structural detail at different depths. It cannot be used as a standalone tool, but it can be used as part of the multimodal imaging platform. Thank you.
Thank you, Dr. Manoj. I'll just ask Dr. Shane to get ready, and I just wanted a question. Any questions to Dr. Manoj? Okay, and I just want to ask you one thing. Would you think this is what is your opinion if I say that the multicolor imaging is a wonderful macular screening tool rather than prognosis and
I think as I had shown, it could actually help you to suspect a lot of pathologies that you would normally not pick up, especially with respect to interface disorders and even choroidal disorders. So it's a wonderful screening tool to pick up a lot of macular disorders which could otherwise be easily missed.
Thank you, Dr. Manoj. So we'll take the questions towards the end. I think we have time. Any questions to Dr. Manoj regarding multicolor imaging? So this is Dr. Shane Matthews is going to present something called infrared reflectance, which is some of the parts of the multimodal imaging that we do not really have a good look at it, but has a wealth of information from inside it. Dr. Shane.
Good morning to all of you, and thank you for inviting me for this talk.
Okay.
In the next 10 minutes, I will be talking to you about infrared reflectance, a basic principle of infrared reflectance, and how to identify a couple of important lesions on an IR image, as well as how it has got a role in present-day multimodal imaging. So basically, infrared reflectance image is taken by throwing an infrared light onto retina and taking an image. So why infrared light? Infrared light penetrates the neurosensory retina and reaches the RP and the choroid in much more precision. So the subretinal features are very well made out. Infrared light is normally coupled with a confocal scanning laser ophthalmoscope. That's why we see high quality image with great precision. Once the light passes through the retina, they get reflected at different layers of the retina. Some of the light gets reflected at the level of ILM, some of them gets reflected at the level of photoreceptors and the RPE, and some of them gets reflected at the layer of sclera. So the reflected light is basically captured by a photosensitive area, and then an en-face image is created, and that is why we see a grayscale fundus image. This is probably one of the important slides of the presentation. One need to remember that fibrin, melanin, collagen, etc. are reflectors of infrared light. So they are seen as hyper-reflective bodies, and subretinal fluid, blood, etc. are absorbers of the infrared light. So they are seen as darker areas. Again, the level of reflectance depends on whether the lesion is found below or above the retinal pigment epithelium. Because retinal pigment epithelium has got a lot of melanin, they are bright or reflectors of infrared light. So the right hand side is an autofluorescent image, and the left hand side is an infrared reflectance image. So how do we differentiate them? If you look at the autofluorescence image, the blood vessels are very dark when compared to infrared reflectance image. And the optic disc details is no more seen in an autofluorescent image, whereas it's much more well recognized in an infrared image. The choroidal vessel details are not so seen clearly in an autofluorescence, whereas in infrared you can see that. Normal macular area is seen as a homogeneous reflective area with a hyporeflection towards the center of the macula. Sometimes one may see a hyper-reflective spot right there at the center, which is nothing but a ghost image, mostly seen with pseudophakic patients. You may see that in other patients too, but it's a ghost image. One of the prime importance of infrared imaging is in cases with media opacities. Take this case of a patient with a neovascular membrane with cataract. Infrared imaging shows a hyperreflective area corresponding to area of retinal pigment epithelial defect, which is not seen on a fundus imaging. So fundus photography stands inferior at this point, especially in cases of media opacities where infrared reflectance image has got a better clarity. Drusens are yet another area where infrared reflectance scores over conventional fundus photography. We know that we need to divide between early, intermediate, and late AMD for prognostic factors. So it is important to quantify drusens. So in this infrared reflectance, small and medium-sized drusens are mostly hyper-reflective, and large drusens or drusenoid PDs may have variable reflectivity depending upon the level of or the amount of RP above them. Reticular pseudodrusens are very important to pick them up because they have a high risk of development to advanced AMD, and reticular pseudodrusens are seen as hyporeflective areas with an annular hyperreflectivity, the so-called target sign. Geographic atrophy was divided into a unilobular variety and a multilobular variety with infrared imaging, and now we know that the unilobular variety is nothing but joining together of the multilobular variety. So it is very good by doing this imaging to reproduce or to follow up this patient to see for progression. Infrared image shows a hyperreflectivity in areas of geographic atrophy because the bare sclera reflects infrared light. But in an autofluorescence, the area of geographic atrophy is seen as dark. A classic neovascular membrane will have a hyporeflective center followed by an annulus of hyperreflectivity. Again, the amount of reflectivity depends upon the presence of blood, hard exudates, or even subretinal fluid in and around the active neovascular membrane. An occult neovascular membrane will have a jagged area of variable reflectance with an ill-defined margin. Retinal pigment epithelial detachment is almost always hyporeflective with a hyperreflective surrounding area. Interestingly, one study said that if you see a hyperreflective center for a pigment epithelial detachment, These are the detachment which is more prone for developing an RP rip. Fluid is an absorber of infrared reflectance, so it should appear as a dark area. So is this case of a tributary retinal vein occlusion with retinal edema. An epiretinal membrane is seen as a hyporeflective area with an ILM striae seen radially going around. Subretinal fluid in case of a central serous retinopathy is hyporeflective. And a choroidal nevus, which has got a lot of melanin, is hyperreflective. So these are a few examples of the hyperreflective and hyporeflective lesions in the fundus. A myelinated nerve fiber, because myelin is a high reflector of infrared light, is seen as a hyperreflective body. The same autofluorescence seen as a hyporeflective area. So as any modality of investigation, it should not, infrared imaging should not be valued as a single investigative tool, but it should be combined with multimodal imaging. This is the case of a polypoidal choroidal vasculopathy. The fundus image does not show the polyp. The endocyanin green angiogram shows the area of polyp. The polyp is not seen on autofluorescence as well, but in infrared reflectance image, the area of polyp is seen clearly. But the autofluorescence here tells us the health of the retinal pigment epithelium in the macular area, in and around the lesion. But the infrared shows the area of polyp clearly. So multimodal imaging is the way to go. And this is a case of occult membrane. The area is well delineated in an infrared imaging when compared to a fundus photography or an autofluorescence. This is a case of Chloroquine Maculopathy. The area of maculopathy is well delineated with infrared imaging. So the advantage is that it's a non-invasive technique, and the invisibility makes it better for children and light-sensitive patients. It detects pathological changes despite the presence of media opacities, and it helps to visualize subretinal features. Limitations are that it's an en face two-dimensional image. It's monochromatic, and it helps us to see the macular area, but the peripheral images cannot be taken clearly with this. Infrared band enables subretinal structures to be emphasized at the expense of other layers. To conclude, it's an adjunctive to other imaging, and it has become one of the important part of multimodal imaging. Thank you.
Thank you, Dr. Shane. Just one point. In which group of conditions do you think that the infrared reflectance would really make a difference in diagnosis?
Dry form of age-related macular degeneration is one area. To pick up the drusen, studies have shown that the reproducibility is much better with infrared reflectance imaging rather than conventional photography. So that is one area I would say.
Thank you.
I now invite Dr. Unnikrishnan. He'll be speaking on en-face imaging.
Good morning, and thank you everybody for coming for the course. So I will just be dealing with en-face OCT imaging. So we have different modalities in imaging. So we have all these images. So what is the difference between OCT and all the other images? So this is something I'd like to stress first. The difference is, so what does all these have that the common regular OCT does not have? And this is the answer. This is what the OCT does to you. It gives you a cross-sectional analysis, while all the, and what happens to a cross-sectional analysis? Suppose this is a layer of cream inside a cake, and suppose you took OCT images at different areas, and where the cream is missing, this is what you would find. And when the cream is there, this is what you would find. But it would not give you a whole description about the cake that it was missing in this area. So that is why this is what the en-face does to you. It cuts the cake along this axis and lets you look from the top. So it lets you look at different areas. At the base, okay, there's cream. There was no cream at this area. At 25%, at 50%, 75%, it lets you look at the correlation of each layer to just a layer above it or below it. So this is what it gives you: perspective, objective, and it gives you the top-end view, something a regular cross-sectional OCT does not give you. And it has been the precursor to OCT angiography and also to adaptive optics. So let's think of understanding the change when you look at an en-face OCT. What does it do? It gives you cohesion, allows quantification, a shift to tridimensionality, Ideal concavity, I'll be explaining that. So this is a regular patient where you're using two modalities of forward on view. That is your multicolor. You see the reflectance here, and then you see area of SRF here. You have quite a amount of information from it. But this is what I meant by cohesion. This is a multicolor image where you see different colors representing different things. A dilated choroidal vessel, you see an area where it is elevated, and then you see the SRF. So this is the kind of importance we have in especially conditions like CSR, what the on-fast does to you. It allows you to see various amounts of quantification. So this is how you used to measure SRF. Look at the area where the elevation of the photosensitive layer happens. But now this is a much better way to measure the sizes of PED and SRF. By taking a cross-sectional on-fast view, you can go end-to-end and measure in each and every quadrant what is the level of the SRF. So what do you mean by tri-dimensional? Does not mean three-dimensional viewing. Tri-dimensional means you're including the Z offset, that is the vertical offset in all your calculations and all your measurements. So you're empowering the Z axis, and it's a concept change because you're looking from the top. Why? The retina is a three-layered structure. It's a multi-layered structure. You don't look at the side. You're peeling off each level when you're doing the en-face imaging, and this is the most important. You need cohesion. Okay, so the cohesion is the most important thing. It tells you what is the relationship of an area to the adjacent area, an area to the what is the relationship of a pathology to the pathology above it. And for doing a beautiful en-face, this is the most. Your system has to have true tracking. It has to capture every image at exactly the same point. I'm just showing you. In CSC, these are the pathologies. You have an area of dilated capillaries, choriocapillaries. You have choriocapillary loss or decrease, an area of hyperreflectivity, and an area of hyperreflective SRF. So in sequence, when the scan goes, this is what happens. At the area, you see thickened vessels, and you see an area of hyperreflectivity, and above it, you see, this is through the choriocapillary level, there is an area of choriocapillary loss just above the PED in CSR. So these are information that you can get on an en-face image. So the key to an en-face is to find which level to go through. So these are the two. This is a PCV patient. This is a classic description. When you go through the RP level in a PCV, you have a wrinkling, like a wrinkled carpet. So here, but if you take a, if you're not imaginative and you just take a straight line somewhere, you get features like, you just get a pachychoroid feature and doesn't bring out the exact feature. So this is called ideal concavity. You have to know where to take the ideal concavity. So it is the RP fit if you want to study the outer retina, is the ILM fit if you want to study the vitreoretinal interface. So if you want to study the vitreoretinal interface, you have to have your cuts going through the scar tissue. And if you want to study the pachychoroid, you know it has to be parallel to the RP and displaced downwards into the choroidal vessels. And here you can see the pachychoroid vessels excellently well on an en-face image. But this is important. A B scan, an OCT B scan needs only one good scan, but an en-face needs one good slice, but an en-face needs a good scan throughout. Just a few examples. These are beautiful images. You know what a macular hole looks like, but this is the relationship of the cystoid spaces with the macular hole. You can see how much of the surrounding retina is actually affected in different cuts. You can see this, higher cuts and lower cuts. You can see these are kind of like two levels of spaces, and as you go deeper, it all coalesces, and at the base of the hole, obviously you see just the hole. So beautiful images about macular holes. DME, the level of the cyst in different areas can be seen. And as you go down, this shows you the ISOS loss or the coastline loss at the lower. The darker areas show you how much is the damage to the deeper layers. So when you see hard exudates, this is a beautiful image where you see hard exudates and encroaching on the fovea. And this tells you about how the encroachment. Here you can see at a deeper layer and at a superficial layer probably tells you that the hard exudates are migrating towards the basal layers of the retina. There's a word of caution. Whenever you see hard exudates, you get shadowing, and when you get shadowing, you get images like this. You feel that the outer photoreceptors are lost, but however, it's just a shadowing effect over there. So I'm just going to skip diabetic TRD. And geographic atrophy is something that is very brilliant. As all the other modalities, the en-face image shows you the reticular drusen extremely well and extremely brilliantly, and the area. This is the appearance of outer retinal tubulations. Okay, you can see all these beautiful areas where the external limiting membrane is coiled upon itself, and this happens over a scar, visually seen as a round structure, but this is actually how they look like, scrolled ELM. So there are two types of ORTs. In neovascular, it's called pseudodendritic, and in atrophic, it is called perilesional because they're at the edge of the lesion. So even you can detect, without the presence of an OCT angiography, sometimes you can detect occult CNVMs using UNFAS at the right plane. PCV, as I said, you can get a wrinkled appearance when you do through the this cut, and deeper it corresponds to the dilated choroidal vessels. Very carefully, sometimes cut just underneath the level of the the PED, you can see polypoidal lesions as well. So this is definitely a precursor and adds a lot of information to the OCTA. Beautiful images of choroiditis. This is a white dot syndrome where you see at the level of the ISOS, so the coastline, you can see a damage just a level beneath it. There's not an issue. Beneath it, you see choriocapillary loss. So that corresponds. Choriocapillary loss leading to photoreceptor damage in white dot syndromes being a primary choriocapillariopathy. Just showing the image once again, you can see the flickering of the image, and again beneath it the loss of the choriocapillaries. All this is NFAS without OCT angiography. Again, mudes, you can see the loss of, in the healing, see the loss of the photoreceptors at different points. Posterior scleritis, you see a bumpy choroidal contour, a lot of lesions, and after healing, you see in areas where all those dark areas seem to just go away, and then you have a bit of residual loss of some of the layers. Beautiful images of CSR. This is a multicolor image. This is what an OCT, regular OCT would do for you, but an OCTA gives you much more information. You can see through different layers, one PED, and then when you take larger scans, you have the PEDs in relation to the optic disc, and that's how informative it is in CSC. So I'm just going to show you this image. Goes just under the PED where you see a hyper reflective at the layer. You see, this is a beautiful image. Coiled vessel. The diagnosis is not, it's probably a PCV lesion, not a thing where you see a neovascular component also inside the PED. Dilated capillaries at the area of CSC. You see it goes way down over there. So this is sequential pathology. How to differentiate acute and chronic based on NFAS. In acute CSC, the PEDs are highly circular. 45% are circular, perfect circle, circular or oval. Irregular is very rare, but never multilobulated. But when you go to chronic CSR, the PEDs become multilobulated, the circularity comes down, the irregularity index goes up. So that's how you can differentiate chronic CSR from acute CSR on and UNFAS scanning. Again, pachychoroid, you see all these thickened dilated vessels. I'm just going to skip through all of these and just go through MACTEL. You see MACTEL images, you see the choroidal space, but on the next image, you actually see the vascular changes of the MACTEL being hyper dense on the UNFAS scanning. Again, this is without OCT angiography. Again, another case of MACTEL. However, this is proliferative, and you can make out the classic CNVM without OCT angiography. So when you compare PEDs, as I said, in CSC, PEDs were circular and very regular. Neovascular, they were irregular. The PED wall is thicker in AMD compared to CSC. Very important key points. I'll just, I have only 2 more slides. So this is an example, CSC PED, perfectly round, very thin, like you've drawn it with a compass. Here, this is an irregular PED, has content, thick walls, irregular walls, multilobulated. So 2 points in differentiating PEDs on NFAS without an angiography. So this is what NFAS does to you. These are 2 beautiful pairs of eyes. This is what the OCT does for you. It gives you a small slice of the picture, but sometimes you need a more cohesive and more overview of it. You have to relearn how to look at the retina. These are the actual 2 pictures where the eyes were cut out. So this is sometimes you need a cohesive view of what is happening. So thank you very much for your patience.
Thank you very much, Dr. Unni. That was a wonderful presentation, and this is one way we need to really start looking at the retina, which we weren't in the past. So I just have one question. In your busy practice, is there any particular indication where we would actually go back and spend time to look at it? Because I know in all pathologies it not be possible, but would there be any particular indication which you would want to do a look at the NFAS and scroll?
For us, it's very simply, we order the NFAS for all our patients. It's just a protocol.
Okay.
But we use it mainly in AMD, PCV, CSR patients where you need to know the outer retinal health much more. The PED status, the content of the PED, it helps really a lot. For me, I'm still learning how to use it properly in diabetic macular edemas and vascular diseases. But anything underneath the choroid, at the level of the RP, it's a wonderful tool.
Thank you. Any question from the audience? So we move on.
Dr. Only one question. Now, how do you obtain this NFAS image? Can you do it in all machines, or do you need to have some specific way of obtaining these images?
It is present in, say, I have used, essentially, I've just used two machines, the Zeiss machines and the Heidelberg. In the Heidelberg, it is standard. If you select a protocol, you can analyze it using the, it's a analysis protocol, basically. Anything that takes a raster, multiple sections and multiple layers in a very fast machine, you can do it, and you can just store the image and see it whenever you want. The Zeiss, I know, has it because it has got a macular cube with advanced visualization capabilities in which you can take images of it also. I'm not too sure about the other machines, but it is not a separate scan. It is you can incorporate it in your regular. You can tell your photographers, all cases of AMD, all cases, you just do a on-fuss along with it, and you just keep it for posterity. When you want it, you have a look at it later.
Yeah. It's not an image which is taken separately, so it's all built up from, like you said, the B scans. So that information is already there. It's just that analytic has to be there in your implanted software. So even Spectralis, from the Spectralis point of view, they have that. So the basic versions don't have that, but that information is still there with the basic version, even the cheapest Spectralis. But going forward, as you go with the advanced one, they just put up that software there on the platform, and that is built up. So it's just a translation. Yeah. No, if it's closer, you get a more high resolution on-fuss. If they are more separated, you get a low resolution pixelation.
So I now invite Dr. Anand Rajendran to speak on the real uses of OCTA in AMD.
So good morning, everybody, and let's thank Guni for having me here. So OCTA is actually the stuff of a conference itself, standalone, and I think in Europe next month there's an entire full day conference on OCTA. So I'll try to roll it in 10 minutes. So, the three musketeers of AMD so far have been, the invasive fundus fluorescein angiography and ICG. OCT, of course, the redoubtable OCT held its own. And now the new kid on the block, or the fourth musketeer, is OCT angiography. So fundus fluorescein angiography has been the gold standard for diagnosing and classifying CNVMs. ICG has delineated the entire extent, and we seem to get a little more about the entire extent better, and also more importantly helps us distinguish AMD from PCV. OCT gives us structural imaging of the thickness, as we've talked about, intra and subretinal fluid, PEDs, and of course a qualitative and quantitative assessment. OCTA helps us look at those small neovascular sprouts which tend to be the early progenitors. It delineates it very well. Now, whereas conventional angiography, this is often concealed by late phase hyperfluorescence, and this hinders the precise characterization of the vascular features. Also, conventional dye-based angiographic fluorescein carries a risk of anaphylaxis. So OCTA provides a clear, depth-resolved, dye-less visualization of the retinal and choroidal microvasculature. Basic principle is motion contrast imaging, in one phrase. RPC movements of the erythrocytes are mapped over time by comparing sequential OCT B scans at co-registered point locations. Various algorithms are there. The most popular ones are the OMAG, or optical microangiography, patented developed by Ricky Wang for the Zeiss systems, and the SADA, or the split spectrum amplitude decorrelation angiography used by many systems, most importantly the RTView. So benefits of any diagnostic are prediction and prognostication. So detection of neovascularization in AMD and PCV based on boundary-specific segmentation is required. Different segmentation strategies are used and based on the location of neovascularization. The ORC slab, the outer retina to choriocapillary slab, detects all macular neovascularization. Now CNV is now being called macular neovascularization. Outer retina to RPE slab detects type 2 neovascularization, and RPE to choriocapillary slab detects type 1 neovascularization and helps distinguish this from PCV, as we'll see a little later. So this is the RPE segmentation line, and this is the RPE fit, or the Brooks membrane. Now when you want to optimize this visualization for CNV or PCV and minimize projection artifact, one can either play around manually, or move it around, change the thickness of the RPE fit slab, or change the position of the RPE fit slab by moving it around. This particular article by Koskas very beautifully highlighted predictive features of OCTA for NV neovascular AMD. They looked at 126 AMD CNV eyes, 90 eyes of which had exudation. The study aimed to evaluate the predictive role of OCTA features in assessing CNVM status and then develop a mathematical potential predictive scheme, which is what we're interested in. The structural OCT they used was a spectralis system. The OCTA was the swept source OCT on the TopCon Triton system. They used automated 30 micron segment slabs, which they moved manually from the RP to Brooks. All patients had the conventional fluorescein OCT imaging and OCT angiography, and all were on obviously anti-VEGF treatment. So 4 OCT angiographic morphological features were assessed: tiny branching vessels, vascular loops, peripheral anastomotic arcades, and choriocapillaris hypointense halos. The tiny branching vessels, which are thin tangle capillaries, we'll look at it in a minute, and the vascular loops, which are peripheral connections between these tiny branching vessels, were above 80%. Peripheral anastomotic arcades, which are inner anastomos between tiny vessels, and choriocapillaris hypointense halos, which is because of the choroidal low flow along these vessels, they were lesser. A summation of all 4 of these yielded the highest predictive value for exudative activity, about 98%. The most reliable 2 of these were, of course, the tiny branching vessels and the vascular loops, which had the highest correlation with treatment decision as well as the highest relative risk for exudation. So these are the tiny branching vessels seen there, and the peripheral anastomotic arcades, the vascular loops within. So this is an example of, this is slides courtesy my mentor, Dr. Phil Rosenfeld, who uses the Plexilite system. And this looks at a case with different components, and this showed beautifully the role of OCT angiography high level in detecting or delineating these components. So you have first the on-fast OCTA, then you have the on-fast structure, which Uni has talked about, and then the OCT and the slab is showing the flow, the slabs used for this particular component, and the structural OCT with the slab and flow subtraction. So just this OCT below. So you see first you have the type 1 MNV component, and then as the slab is moved up, you pick up the type 2 MNV component. So beautifully you see there are different locations, and the composite, when you move, you have these 2 slabs included. Another example where you have a very separated type 2 MNV component and type 1 MNV component, and you see the entire component. You see how the lesion is, you can actually look at the different components in isolation. This is an example of a patient with a very high type 1 or occult CNV component. You can see the entire extent here, and with a small nest of the type 2 MNV component, or the classic component above that, and the entire component here. Another example of a patient who had predominantly regressed CNVM with a recurrence happening, and you see that on either side of the predominantly scarred CNVM here, which is hypo, you see the nasal type 1 MNV component, and when you move the slab above, you see the type 2 MNV component and the entire composite MNV component. OCTA finds a lot of utility in RAP, or the type 3 macular neovascularization, the classic RAP location with early phase and the late phase fluorescein angiography, the classic structural OCT with the PED, and the stage 3 RAP showing up, and you see the OCTA of the RAP as a world lesion right here and in magnification out here. This is an example. So looking at, it can also be used, as I mentioned, to prognostic or track changes. So this is an example of a 76-year-old lady who came with 636 vision with pre-treatment picture, the fluorescein angiographic depiction of the RAP lesion, the classic OCTA of the, structural OCT of the type 3, stage 3 RAP, and the OCT angiogram, which shows the RAP lesion very beautifully. Post aflibercept, a couple of things. You can see the remarkable resolution on the structural OCT, as well as almost a complete clean out on the OCT angiogram. In RAP type 3 MNV, you find this, the cystic changes, kissing sign B scan with the flow, the color-coded retina, and you see the entire composite of the on-fast angio, the ORC slab, which shows up the lesion there, and the tighter OR-RPE slab, which shows the lesion also. But these have projection artifacts. Now you're going to see how, when you clean up the projection artifacts, you find it so better defined. In PCV, this is where I think SSOT is going to have a big role to play. They have find the polyp, the double layer sign. You can see the OX slab and the on-fast angio, which shows beautifully with the projection artifact removal in place, the polyps and the BVN. And the tighter RP choriocapillaris slab, which shows this. So this is almost, you can almost do away with ICG angiography if you have this in place. Again, another example with the color fundus photo, the fluorescein and the ICG angiogram, which shows the polyps and the total retinal flow, and you see again with projection artifact removal, the polyps and the BVN showing up almost as well as you would expect to see with the ICG angiogram. So this is the marquee use, I think, of OCT angiograms, a beautiful publication which came out last year, probably the landmark publication last year from the Bascom Palmer group again, which looks at subclinical neovascularization in intermediate AMD cases, 110 intermediate AMD cases, 50 geographic atrophy cases. 23 out of these 160 had with incidence of 15, almost 14.4% of the subclinical CNVM. So 134 is completed follow-up, 13 showed the clinical CNVM, 10 out of 13, 77% had prior detected subclinical CNVM on swept source OCTA. So eyes with subclinical CNVM that went on to become clinical CNVM during the course of those 3 years of study, 21%. Eyes without subclinical CNVM which developed subclinical were only 3.6%, which is statistically a significant difference. No difference in cumulative incidence was seen between intermediate AMD or geographic atrophy, which means both can develop the subclinical CNVM. After detection of a subclinical CNVM, the risk of a clinical CNVM developing is 15.2 times that of eyes that do not have this picked up detected subclinical CNVM. So that's a major finding. So this is an example. This is a subsource OCT showing the subclinical CNVM at baseline. The Oct lab you see here is there, and then 4 months later you see that becoming more intense, and then 14 months later you see how the subclinical CNVM is progressing. The patient is asymptomatic throughout. This is an example showing why this is important to look for. This subsource detects this and then shows conversion to a clinical CNVM, where you have this lesion here at baseline becoming a little larger, but still you see the structural OCT, there's hardly any change out there. But then just 2 months after this, you see suddenly a sort of popping up, and then you see that this has actually increased, and then a month later, you just finish in a couple of minutes, a minute or so, and you see in 1 minute, in a month's time, you see that this has become clinically significant, and this patient was treated with aflibercept. So limitations of OCT are large PEDs, subretinal macular hemorrhage, severe pigmentation, severe scarring or gliosis. There'll always be a challenge for them to move out. So with advances in OCTA, dye-based angiography may no longer be needed for neovascular AMD, probably in 3 to 5 years' time. It's predictive, it detects subclinical CNVM, as I said, in non-neovascular AMD, helps tailor the follow-up. You can, when you see that, you can decide when to call the patient if you're seeing it growing faster. It helps you strike earlier in subclinical CNV cases. It's early predictor of exudative CNV activity, as we showed those features, tiny branching, vascular loops, etc. Distinguish, as I showed, between the different types of MNV, type 1 and type 2. Very importantly, helps characterize a look at type 3 or RAP. Early detection of a recurrent MNV network, as we saw an example. And very importantly, swept source OCT, I think, is going to have a great future in the imaging of neovascular AMD, especially in detecting type 1 MNV and distinguishing from PCV, where I think the role of invasive ICG angiography is going to reduce. Thank you. So I always like to tell my residents and my colleagues that right now OCT angiography is like your iPhone version 1.0 or 2.0. It's only when it makes that jump, when you have when the projection artifact removal is cleared out. Right now there are still a lot of I didn't want to go into those. Mirroring, the projections are still there, and that's what I think. Some systems are a little ahead, some of the Zeiss systems are a little ahead, whereas some of the other systems are falling back. So, and the other thing is also unification between angiograms. There was a publication by Giovanni Storangi where the same patient was seated on 4 different systems, and the CNV size was different in all 4. Now that doesn't happen to that extent with structural OCT. So that is one particular challenge. But for the deeper layers and for this thing, as I mentioned, by my ballpark figures that within 5 years probably we'll be reducing the amount of invasive angiography which we'll be doing. Certainly we'll probably reduce doing a lot more fundus fluorescein angiography than this thing. It has a big take for us, which is why I emphasized on this thing, Swepso's OCT, because I think about all of us will agree that at least 25 to 30% of our macular neovascularization is PCV, as opposed to in the West. So in the Asian population, if Swepso OCT becomes more financially viable, I think that will also reduce the impact, the requirement for ICG. So I think Darius has a flexi light, so I think he may also like to comment on that. We'll go forward. Yeah.
Thank you, Dr. Anand.
What percentage of patients you actually have to go to the machine and, for a patient?
So that's what. At this point of time, like I mentioned in that little cartoon graphic, we almost always have to do some level of manual manipulation to get that exact slab fit. That is going to be the biggest challenge. That's why I put those limitations also. And a lot of our patients will have all those limitations, scarring, large PDs. So you'll have to actually move that thing around to look at it. The biggest challenge for the system will be to automate that. And even if that does happen to a certain degree, you'll have to go back and look at it. So the thing is, the good part is that the image is already acquired. You don't have to do it at the time of acquisition. You can always go back and look at it.
And non-AMD uses just a line.
Yeah.
Okay. So on cue, Darius has come on stage on cue, and he'll be describing to us where, in other than AMD, how the OCT is going to make a difference for us. OCTA. So do we have any questions to any of the previous speakers? In that meantime, we can take something. Dr. Anand, would you start treatment without an ICG nowadays, just based on an OCTA?
See, I'm still in the at this point in time, validating that technology. So as of now, it's not possible to say that OCT angiography is the gold standard. The gold standard still is ICG angiography. I'm presuming you're talking about PCV rather than this thing. So you have to demonstrate. Right now, we are demonstrating structure. What angiography does is it demonstrates function also, in the sense that it shows how much is leaking, whether it's leaking, and where it's leaking from. So ICG not just helps me diagnose, it also helps me treat that patient by knowing which area is leaking more and which area is quiescent. So still at this point of time, I'm using OCT angio. Like I said, it's still version 2.0. So we're just waiting till 5.0. So to answer your question, I don't use it as a standalone to treat, but I use it to understand the pathology better.
Thank you. Dr. Dhanesh.
Thank you so much, and thank you to Dr. Unni for inviting me. So I'll be highlighting some of the other pathologies. So what is the highlight of OCTA? It helps you go deeper, so you can see what has never been seen before. And in the periphery, you can go wider, and you can see what has never been seen before without a dye. So these are the two things I'll be covering in my talk today. So here's a little bit of anatomy. What I would like to point out in this is what has never been seen before. What I said was that the retinal capillary system in the central macula is a layered structure. And basically what is important to know is that it has a superficial, which is seen above, and a deep plexus. The main point is that latter consists of the intermediate. Yeah. So the intermediate and the deep layers. So these are what are lying along the inner nuclear layer. When you go back to anatomy, you can see. I think this. Sorry. Which consists basically the layers of the bipolar cells. So this is what we need to concentrate when we see this. Second point to be remembered is that any vasculature seen here in this avascular should ring alarm bells and should make us look out for some neovascular process happening. So these are two important points which we should remember as we proceed. I start with a case which has been challenging me since 2012. He was a 64-year-old gentleman, history of porphyria, and he says he came in 2012 with something like this, and we just said let's observe the left eye because there seem to be chronic changes. 2015, after 3 years, he came back, and you can see a pocket of fluid which is there in both the eyes. Here I'm just putting the scans together, 12 and 15, something is happening. So we did the traditional imaging, no polyps on, at that time we didn't have Heidelberg unfortunately, so we did the flash ICG and something which we thought looked like a small CNV on FFA, and we gave anti-VEGF injections. After a month of the last anti-VEGF, he said he was getting blurring. So we don't know what is happening. Basically, we are giving anti-VEGF, which is at that time Lucentis, and he was not feeling better. The fluid is still there. So this is where OCTA, which had just come out at that time, came to our rescue. We went and did a OCTA, and we could see beautiful vascular loops in the right as well as the left eye. We did a swept source imaging, which found the choroid to be much thicker, more than 500 micron in both eyes. And wide field, this is the beauty of multimodal imaging. You can see these beautiful tracks on the hyper tracks seen on wide field optos, autofluorescence. So this is when we started reading up, and we realized that ILIA, which works better for the type 1 CNVMs, started in India, and we used ILIA. And for the first time, because of aflibercept, this gentleman was dry and happy. You see the fluid is dried in both eyes. And I'm not going to bore you. I've got millions of scans for this patient. But now with the swept source OCTA, you can see these beautiful loops in the right and the left. And this is what now I kind of use to titrate his treatment. These loops kind of go away with the therapy, and they do come back. So this is somewhere where OCTA helped us. We realized it was not CSR. It was actually AMD, A. B, he had porphyria. I could not do a PDT for this patient. So it was critical to know the diagnosis in this one-eyed patient. So just this was the points which this raised up, and yes, no doubt that it helped us in this patient who had a combination of a pachychoroid with a vasculopathy. So now we come to a second interesting thing. In fact, Dr. Shahana is right here. We shared this patient with her also. This was a 35-year-old patient who complained of a scotoma, and this is one thing which we called middle maculopathy. So you see that the layers are okay, but the inner nuclear layer is hyperacute. He had a cilioretinal artery occlusion. See the whitening here, and see how beautifully you can see the superficial layers are not looking so bad, but the moment you see the deep layers, you can see the hypoperfusion. Anfas also shows this, as Dr. Uni has also shown us beautiful pictures, and this is something which we can really make out and see only using this segmentation or layering, like the cake he showed us, using the OCTA. This is another case where this is a very short video. I hope it runs. Video. It's in the part of the presentation. I try to show it at the end.
It's running, it's running.
Huh? Okay, keep looking inside. Keep looking here. It is a vitelliform, and look inside what we are finding. So in vitelliform, sometimes when we have a CNVM lying inside it, it's very difficult to see because you just get a lot of fuzziness. You are not able to see the membrane clearly, but because of the OCTA, we could actually make out there was a CNVM inside and treat this patient. Another disease which OCTA is very, very important and useful is, and coming up, is MACTEL, or idiopathic perifoveal telangiectasia. This is the classical classification by Gass and Bloody. I'll not go into this. But the later classification has come out based on OCTA. I think we can't go into details, but just that grade 1 has the normal superficial and the telangiectic vessels which are there in the deeper layers. Grade 2 has some abnormality up also and in the deeper ones. Grade 3, you have to notice that invasion of the FAZ occurs and you have pigment accumulation, and grade 4 is the one with the CNVM. Let me just go on to showing you the pictures. So here you can see a patient of ours with grade 1, but you can see the telangiectic changes happening on the temporal aspect in the deep layers in the eye, whereas superficial looks almost normal. Here is a grade 2 where you can see mild changes in superficial but marked in the deep. Here you have grade 3 where you can see FAZ is irregular, some vascular invasion is taking place, pigment accumulation is there which is causing the shadowing. And most importantly, grade 4, which according to them is the one with the CNVM, in the avascular slab you can see something happening. And when something happens here, you have to be, your antennas have to stand up that there could be a CNVM in this patient. So now we have gone deeper, we have dug in deep into earth. Now let's go wider. So let's move focus. And this is an excellent, for patients with deranged kidney functions, it is excellent because it can be done, A, and secondly, you can repeat it, because if sometimes you can do one angio, but you may not be able to repeat it in patients with deranged systemic parameters. So with the wide field swepsos, fortunately we are able to take 15 into 19 slabs, 12 into 12, and even go as wide as 22 into 22. So this is a patient, this is the conventional imaging. Angiography, you can see the new vessels, capillary non-perfusion, and you can see how beautifully the vasculature is delineated on OCT angiography, and even the beautiful details and the capillary non-perfusion is seen in great detail without the use of any dye in this patient. This was one of our cases which we published recently. So this was a patient who had neovascularization, and this is above is these two are OCTA, and this is the fluorescent angiography, and this is pre-laser, and this is post-laser. You can see the regression beautifully, and best is through this, if you take a section through, you can see how the new vessels has become thinner. And this was the IGO publication, and you can see above the red dots show the flow. So you see how much the flow was pre-treatment, and post-treatment there's only this little bit of tissues there. It's become thinner, and the red dots have also decreased, showing loss of flow post-therapy in this patient in a non-invasive manner. This is one of my favorite personally images. This is a neovascularization NV near the disc, and you see this was a patient, and this was taken 3 days after anti-VEGF. This is a color photo, and how you can see the regression of the NV beautifully without use of any dye using the OCT angiography. TRD, so this was a lady we were following on OCT angio. See how bad the tractional retinal detachment has become. And this is after anti-VEGF with vitrectomy. The same patient, it looks much, much better. So I'd like to conclude with 3 tips for interpreting OCT angiography. Please analyze layer by layer. Always correlate with B-scan, and as we heard with Dr. Only, the en-face images. And analyzing the video helps in reducing the chance of artifacts, which are very, very common with this technique. So OCTA is very useful in AMD, as Dr. Anand said, and also in cases where lesions affect deeper vasculature, like middle maculopathy, MacTel, you can see the stages beautifully, and you can, the segmentation helps to distinguish choroidal neovascularization membranes and patients with kidney dysfunction. So monitors therapy and response to therapy, and it can be done frequently without fear of any systemic problem. Thank you so much.
Thank you, Dr. So that was a wonderful presentation. Some of the brilliant images, especially of the neovascular membrane inside the AVD. That was a beautiful image. So do we have any questions to... Yeah,
So which machine is this?
This is a Plex Elite Zeiss machine.
Fantastic presentation. Now, in the first patient, the brigadier that you showed, you said you titrated looking at the loops. What was the OCT showing at that time? Was it showing any fluid, or this was earlier?
I kind of, there were, I think we all have to look at multimodal imaging. So yes, one was the loops were going down, but titrating, to be very frank, was more based on the B scan. But so in fact, this was very, I would like to, when Dr. Phil Rosenfeld came for VRSI and gave an oration, somebody asked him this question, that you are talking about these membranes which are there, but there's no fluid. So will you treat based on these loops? So he said no. So currently, I think we have not, the technology is not advanced enough that only based on this we can treat. We have to rely on the B scan also and the fluid. Yes, yeah, it around the same time, I think. Around the same time, but yeah, it is like, you know, so pre-perimetric glaucoma, so this would be pre-OCT in that kind of manner. Yeah.
There's a very beautiful paper regarding the effect of anti-VEGF on evaluated by OCTA. So after anti-VEGF, the membrane starts regressing in 2 to 3 days. It is regressed to its maximum in 5 to 7 days, persists for another 5 to 7 days. Then around 20 to 21 days, it starts growing back again. So that is the, and even when you correlate it clinically, at your 30th day is when you have the peak effect of the anti-VEGF going down, and not the peak effect, the effect going down. So this is a beautiful paper that takes you to the first 3 weeks. And as he said, when you're observing, there is going to be a lag phase. There are 2 lag phases: appearance of activity and decrease in vision. That is well documented. And the second lag phase is that the appearance of the CNVM on OCTA and the appearance of activity in the form of SRF. There is a small lag phase there also. So over time and experience, we're going to learn how to correlate all these 3 things. Thank you, and I'd like to invite Dr. Ashish to give his talk about the choroidal imaging. We have a keynote speaker, Dr. Noella Prasad. I'd like to know if she's here. Dr. Noella. Okay.
Good morning, ladies and gentlemen. So basically, this was the talk should be given by Jay, who has done a phenomenal work on the choroidal imaging, but unfortunately he could not make it. So we will talk about the choroidal imaging. We all know that choroid has, and these are my disclosures. Why to image the choroids? We have known since long that choroid is an important layer, and over the time, with the help of multimodal imaging and other imaging, we know that ICG was the only thing which we were using before, but it was giving the perfusion analysis. But over the time, as we grown the technology, then this was the first paper which has changed the way we looked at the choroid. The paper was published by the Spade when he gave the first technique that how you can image choroid with even the SD-OCT by giving the EDI, by just putting the zero delay line further back. And in a normal SD-OCT machine, everybody could do it because that is the machine which is there predominantly at each and every center. But what was happening was, that vitreous details were compromised. So over the time, the need was felt, okay, is there any way that we can actually see both vitreous and the posterior most part like choroidal scleral boundaries little better? Then with the help of swept source and the better wavelength, we could see that. And we could see the little larger area also. So the normal choroidal thickness, if you talk about, is 191.5 up to 354. You can see that's a wide range. Why is that wide range? Because the choroid varies with a lot of factors. There are a lot of factors. For example, it varies with the advancing age. It varies with the myopia. It varies even within a day. So that is the reason that you see a quite variability. Even in the range is quite variable. So over the time, initially it was only manual when we were taking the outer boundary, the RP and the choroidal scleral junction and putting the line manually. But over the time, when the meta segmentation came, it became little easier, and over the time techniques have developed that you can actually measure the choroid, for example, with binarization a little better. Then to even just one cut is not enough, so you need to look at the up and down and over the volume what is happening. I think that could give a better information. So that was considered, and furthermore choroidal vascular index was considered, and it was supposed to be a little more stable compared to the choroidal thickness alone. So as on-fast imaging, Dr. Unni has already highlighted beautifully, choroidal contour, 3D reconstruction, we are trying to look at it, OCT highlighted beautifully by both the previous speakers. So let us see what actually we have learned out of this choroidal imaging and what is the kind of importance that you have. So this was the first entity which was again described by the Spade, that what you see is there's a severe choroidal thinning that you see here, but RP looks quite intact. So the entity was age-related choroidal atrophy. So the way you can differentiate, you should not get confused between the GA and the age-related choroidal atrophy, because GA could have a worse prognosis, rather this entity, because the RP is quite intact, so the prognosis is quite good. So you can predict things once you see these images. Further, myopia, with each degree of the myopia, as you can see that choroid gets thinner, but it doesn't, it's not necessary that you can have a correlation with the visual acuity. And again, this is the entity, dome-shaped maculopathy. Again, the concept was cleared after we had this imaging. Previously, the concept was that because of the staphyloma, both the sides of the sclera were sagging in. But actually, that was not right, because the center where the dome is, the sclera was pretty thick. And because of the sclera, there was a compression in the choriocapillaries, which was producing a pseudo fluid. So that fluid you actually need not to treat because it's not a CNVM. Furthermore, CSC management, right from the concept, right from the understanding up to the management, choroidal imaging has really, really helped us, and we have learned a lot. For example, if you see this particular patient, you can see after focal laser, you can see a quite thick choroid, and after focal laser, choroid thickness doesn't change. While after PDT, you can see the choroidal thickness goes down further. So we could understand, both the things both the treatment, they work in a different way, and PDT could be a better option in treating this in a long term. Another disease, which again we learned after choroidal imaging a lot. For example, it has again changed the way we treat them. For example, this is the right eye and the left eye of this patient. At the initial visit, you can see a quite boggy, thick choroid. Actually, you can't even see the posterior boundary itself. But once you start treating them, after 3 doses of the pulse therapy, then in this particular right eye, everything is crescent, even choroidal thickness goes down. Here choroidal thickness goes down, but after the 3 weeks of the steroid pulse therapy, the recurrence comes here again, but there is no retinal changes here. But as you can see down further, the choroidal thickness comes back. So probably these are the situations where choroidal thickness really helps you. Okay, now the recurrence is going to come in this particular eye, so you can treat them. And again, pachychoroid, again, the choroid has a really, really important role. Our understanding and even the definitions still keeps changing, but understanding is that, outer layer, they are quite big, and they are compressing the inner smaller vessel layer. So it's a kind of a spectrum which starts. Previously, we were thinking in all these, subtle RP changes that, these are probably the healing CSR cases, but probably not. Probably those cases were the initial pachychoroid pigment epitheliopathy, further leading to CSCR, leading to pachychoroid neovasculopathy. As Dr. Anand said, now the definitions are changing. Now we don't call any more type 1, type 2. It's all, whatever vascularization that you have at the macula is basically a MNV, macular neovascularization. And apart from these central macular, you have some understanding of intraocular tumors also. But in terms of the tumors, actually, fundus photograph gives you quite a lot of information. But still, there are situations where you can differentiate. For example, in a melanoma cases, you can see a gentle dome shade, quite a smooth surfaced area down. But here you can see in cases of hemangioma, a lot of hyporeflective vessels that you can see underneath. So you can differentiate. In metastasis also, there's a lumpy, bumpy RP, but you can see the choroid, and further back you can see the sclera, which you don't see in cases, for example, sclerochoroidal calcification, because the sclera is coming from the down, and it is basically compressing the choriocapillaries. In lymphoma also, you have the lumpy, bumpy, but basically there's a quite huge undulation, which we call as a C-sick appearance. Osteoma is actually, you can't miss it even with the help of fundus photograph, but still, if you want to image, you can see the intralesional horizontal lines. So now you can ask that why are you not talking about the AMD, DR, retinal dystrophies in cases of the choroidal imaging? We are still not clear, because the AMD has a multiple component. Now we are growing towards trying to define and separate the AMD as MNV, and even the choroidal thickness. In a few slides I will say that how the AMD would change in future. So this is again, when you actually measure the scleral thickness with the help of your caliper, sometimes it's not very easy to find the boundary which you have at the at the back, because there are multiple times there is a fuzzy kind of bend that is there, and that is called the suprachoroidal space. Probably in few eyes you have that suprachoroidal space, but if that is that is the case in many cases, then probably the entire thickness, because it's all about the millimeters, entire thickness might go in a haywire. So that concept we need to still clarify. So for that, there is a good paper where you can actually check the scleral thickness in 3 ways, which whatever inner area that you see, that could be the vascular choroidal thickness, in between the stromal choroidal thickness, and the last line, this could be the total choroidal thickness. So if we can divide all these 3, probably we can have the better understanding. AMD definition is changing. If you look at the recent paper by the Spear again, so the way in future, again, things might change. You might, these are all the drusen. We see drusens day in and day out, but you need to really look at the drusen. What kind of drusen are we dealing with? For example, this is the eye of in the left eye, which is we call as a pachydrusen. And the pachydrusen, if you see, on the affected eye, you have the PCV. On the other eye, you have quite a thick choroid. So, and in the middle, there are soft drusens. In the other eye, there is a type 2 CNVM, while this eye, there's just the drusens, soft drusens. In this particular, these are the pseudodrusens, and then this particular patient, there's a rep lesion. So what is going to happen in near future? You see the choroidal thickness. You have these drusens, and somebody would ask, this is the drusen that you have, and this is the choroidal thickness of that particular patient. So what, so then retrospectively you can answer, okay, this could be the pachydrusen, this could be the pseudodrusen. So in that way, I think we are going in a different way to define the AMD going forward. To summarize, choroidal thickness is highly variable individual, decreases with age and axial length. Choroidal volume shows almost similar interpretation as choroidal thickness. CVI, choroidal vascular index, has little low variability compared to the CT, choroidal thickness, and fast imaging has improved the vessel detection, especially in cases of the PCV. OCTA gives you real good information as the early CNVMs and the type 1 CNVMs, and AMD might be redefined by the choroidal thickness over the time. Thank you.
Thank you, Dr. Ashish, for doing a great job with the choroidal imaging. It's a tough topic, and it was a great lecture. Thank you. Do you have any questions for Dr.? Okay, so.
Yeah, probably if you even look within the 1 week, choroid becomes even thicker. Even the inner retinal structures, you have a little more fluid because the initial inflammation. Probably after a couple of weeks, once you see 2 or 3 weeks, then the choroid becomes thin. Even the subretinal fluid also comes down. Initial, there's a reaction, then there is a subsidence.
So there is a point in that particular thing is that we are looking for, we're not, the PDT just does not just reduce the choroidal thickness, it produces a key element called choroidal remodeling. And for that choroidal remodeling, actually anti-VEGF is a key point also. That is why combination therapy is supposed to be quite important when you're doing thing. That is, the choroid reduces the thickness, but you need a stable reduced thickness. And for that, the remodeling, you want to suppress the VEGF for some time also. So that is the core point in driving forward combination therapy in certain diseases with choroidal pachychoroid syndromes. Thank you. So we were supposed to have a keynote address for 10 minutes, so that gives us 10 minutes left. Do we have any questions that we want? I can just put up, I have just put up one small, very simple case, and which has all the imaging modalities inside it. So I think our panel can discuss it.
What's your take on pachychoroid neovasculopathy? Do you consider them for anti-VEGFs only, or do you go in for a combination therapy, or what's your take on that?
So some people would call it pachychoroid neovasculopathy, some people would call it PCV. So assuming they're more or less the same, my initial take is always to look at the morphology. PCV, pachychoroid is a big spectrum. It can be hemorrhagic, it can be just serous. If it's serous and it's subfoveal, then my take is to go first with anti-VEGF. Ride as much as I can, and then if it doesn't respond adequately, go in for PDT or combination treatment to arrest it. But there are many variables, and I might go either way depending on, like I said, how it is.
Okay, so I'd just like our panel to just have a little, it's a very simple case. So I think Manoj just skimmed through it. Will I lights off, please? Yeah, okay, so I think slightly touched upon this case was. So can we have, first we'll start with Dr. Anand, multimodal, multicolor imaging.
So I think based on what Manoj said, this probably could be a Nevis kind of thing. This reddish, there's no edema over that, there's no greenish stuff. Okay. So looks like a well-defined lesion, possibly.
So why is it reddish?
Well, for one, I think it's the RP which is slightly disturbed, or there's something under that which is, showing up. I'd rather have to see the other three, infrared, green, and blue to make a more educated guess. But the push on the RP, I think, is leading to that discoloration.
So just to touch what Manoj said, there are three modalities, three laser lights going up. The red goes to the deeper, so any disturbance in the deeper layer picks it out as a well-delineated part, differentiating a normal versus abnormal pathology, basically. So this is the AF, which we haven't touched. Dr. Darayas, would you like to comment about this?
Yes. So we can see a lot of mottling of the pigmentation. And normally AF, what they say is the area which is whiter or hyper, it shows more activity of fluid, and the area which is dark, of course, shows the dead RP. So this means it's quite a chronic kind of lesion. And I think this is important to do along with the multicolor. What I found was quite scary with that is that Dr. Manoj in fact showed that case with those red dots. And so I have in fact a question for you. When you see those red dots, you must be very careful because you always think of hemorrhages when you see red. And actually, when you see the actual color photo, you see it's actually black pigmentation. So I always get puzzled when I get only a Heidelberg photo done. Are we doing justice to this patient, or should we also get a flash photography?
So the basic tenet is that you never assess the patient based on one image. So if you know and you've trained yourself to understand that red does not necessarily mean a hemorrhage, then every picture of a
Actually
Heidelberg
difficult for
photo-
us to do because we have to retrain our minds
you
to.
have to retrain
This
your
is
minds.
pseudo color, yeah.
Pseudo color imaging. So
This
one thing interesting, I'll just flip through the images. Larger lesion, smaller lesion. So you have a larger thing picked up on the multicolor
Multicolor.
imaging, and a much smaller thing picked up on the autofluorescence, which is quite an interesting finding over here. Autofluorescence, in one word, is called metabolic imaging. It defines the health of the RP on a metabolic level, basically. Irritated RP is white, dead or loss of RP is black. So this is your ICG picture. Dr. Shane, would you like to?
ICG imaging showing that is 3 minutes and
1 minute 3 and
1 minute and 3 minutes.
3 minute 51.
Yeah. So the central area shows a hypofluorescence in the macular area, and surrounding edge shows a little hyperfluorescence as well. So what about the later stages of the angiogram?
Yeah, I think this is it. 20 minutes.
20 minutes. Okay. So there's no obvious polyp seen. There is no obvious occult membrane as well. And the edges shows little hyperfluorescence, so pronasally.
So it's very unfair to surprise a person with an ICG or a thing, but that was pretty well said. So, and probably nowadays you think that you don't need anything else, you need only the OCT. So this was the OCT picture. So can Dr. Anand?
It looks like a Nevis. There's a push from below, and it's pretty large. The whole thing, this entire shadowing out there. The RP is pushed up. How much is it? 400 something.
Yeah.
So yeah.
Would you like to
That's my
comment
first
about this
instinct.
and how it corresponds to the previous slides we saw?
Yeah, so that's what that RP disturbance is what I was saying. Something is pushing the RP, and that is leading to that reddish discoloration. That's what I would say. So my differential still, I think, is probably a Nevis. Okay.
So now,
yeah, you had to put that in. Yeah. So then you have to say
so everything's going
pachychoroid,
perfectly according to cue. Okay.
neovasculopathy. Yeah, now things change a bit. Yeah.
So, yeah, Shane, please.
Many times I've noticed that some of the occult membranes doesn't highlight on ICG, and you might pick it up on OCT and you treat it and it responds, but it doesn't. It will not be evident on ICG.
Okay. So, Dr. Anand, are you wishing for an OCT angiography now? Okay.
But I just like to look for a conventional fluorescein angiography.
Let's see if I
That
have
would
it.
be
No,
fine.
I don't have it. I have this. So what do we see here? The rise, please.
So in the third, which is we are seeing right in the center.
Yeah.
What is looking like, and so it could be. I mean, we should not comment like that, but yeah, it could be some sort of a choroidal vascular membrane, or looks like a polyp, in fact, in this picture actually.
Okay, I'm going to ask you just one question. Did we actually need to do this? You had a Nevis-like lesion with an overlying PED with fluid. Did you have to think that you needed something else to say it was a neovascular process or not? Clinical question. Did you need to prove it on ICG? Did you need to prove it on OCTA to say you had a neovascular process?
Since you have the structural OCT showing you that there's a RP elevation, which is like a type 1 membrane, and there is some fluid, so obviously you're then thinking it's a secondary CNVM, having seen that large lesion in the choroid, so you know that there is something there. So you would like to know activity. So I would definitely like to do the conventional angiography, as I mentioned. We like to know if it's leaking, if it's something which needs patient. What is the history? Patient was symptomatic or just asymptomatic?
Actually, you're not giving us any history. The
Yeah,
vision,
that's
fluid.
This is like
basically imaging symposium, so it's fine. I'm allowed to do that.
pretty unfair.
My question is, if there was a CNV, why was it not picked up on ICG? And I always wondered why these small CNVs are not picked up on
That's a
ICG.
really nice question. Dr. Ashish, would you like to give us a...
No. One reason for that possibly is that this, the choroid, you see that entire, if you, can you just show that thing? Yeah, that entire lesion, I'm presuming it's a Nevis, has pushed out all the choroidal conventional vessels away. So there's no way that ICG dye is reaching that spot. You understand? Or probably very minimal. So otherwise you should have seen pooling. He's even showed us the very late frames. So the thing has been there for such a long time. It has probably killed all the choriocapillaries out there. And that's why you see it as black. It's hypocyanescent in the center. So there is hardly any choriocapillaries out there at all. So this is actually pushing beyond where the RP would come. So it's completely pushed everything out. So that's why the ICG dye is not reaching there.
One clue you can see is here is that there is no lumen here. There is a very compressed stromal choroidal tissue.
So everything is just stroma there now. There's no vascular lumina.
Yeah, that's exactly what I was going to say.
Yeah.
In
So
OCTA, we see a neovascular process.
yes. See, OCTA is a generated image. How it generates it, we do not know. That is not there. You can actually before this bulk motion artifact technology came in, you can people were getting all sorts of images when the patient moves their head. You know, even it's basically looking at phase difference. So that I would put it slightly on the back burner. Like I said, it's still version 2. But this is why this is not leaking on the angiogram. I would like to see the fluorescein to see if there's leakages.
Unfortunately, we're doing only advanced imaging today.
Old is gold.
So, okay, I think that's about it. The NFAS doesn't show anything much regularity. So I thank you all for coming, and I hope you enjoyed the imaging session today. Thank you. Thank you.